Welcome to Crisis in Perception, where we examine the systems shaping our world. I am so glad you're joining us today because we have a really custom-tailored deep dive specifically for you.
Yeah, we are focusing on some truly groundbreaking source material today.
We really are. We're looking at Troy Tassier's book, The Rich Flee and the Poor Take the Bus.
It's an eye-opening text.
It is. And our core mission for you today is simple, but it is going to completely change how you view public health.
Right.
We are going to completely shatter the myth that pathogens just, spread across a blank map. Disease distribution is not a matter of biological luck.
It's really not.
You'll see how viruses actually travel through the very specific structural channels and, well, the social fractures of our pre-existing inequality.
What's fascinating here is that this is the crucial paradigm shift we're going to explore.
Right.
We are moving entirely away from looking at epidemics merely as isolated medical events.
Which is how we usually talk about them.
Exactly. Instead, we're going to analyze them as highly predictable consequences of how our society is physically and socially built.
So we have a pretty comprehensive framework for you today.
We do. We'll examine the architectural design of epidemic inequality, the complex incentives this architecture creates,
The mathematically inevitable outcomes it produces.
and the persistence of these exact patterns throughout human history.
And finally, the profound interconnections with our broader economic and political systems.
The core thesis we're drawing from Tassier's work is that the biological traits of a virus, they only tell half the story.
And the other half.
The other half, the half that determines who actually lives and who dies, is entirely about the sociological traits of the society the virus lands in.
Okay, let's unpack this. I want to dive right into the physical reality of this, the geometry of it all.
The spatial design.
Yeah, we're talking about how the actual physical and social architecture of our society is literally structured to either facilitate or completely hinder the spread of infectious disease.
But before we can visualize that map, we really need to understand the underlying math of how a spread even functions.
Right, because there's a foundational concept from early epidemiologists that you need to have in your toolkit right out of the gate.
Yes. To understand the math, we have to look back to the early 20th century.
To scientists like Ronald Ross.
Ross, William Kermack, and Anderson McKendrick. They developed the mathematical foundations for what we call the reproduction number.
Which we often see represented as R0, right? Or R0.
Correct.
Yeah.
Ross initially observed malaria outbreaks and realized that an epidemic doesn't just happen because a disease exists.
It needs the right conditions.
Exactly. It requires a precise combination of variables. You need a sufficient population of susceptible people and enough disease carriers.
Which, in his specific research, were mosquitoes.
Right. And Kermack and McKendrick later refined this observation into the reproduction number we use today.
And how exactly is that number defined in a modern context? I mean, is it just an estimate of how bad things are?
It's much more precise than a general estimate. It's defined as the average number of new infections directly generated by each infected person.
During the entire course of their infection.
Right, assuming they're in a completely susceptible population.
Mm.
And the rule governing this number is brutally simple.
It dictates the entire trajectory.
It does. If the reproduction number is above 1, meaning one sick person infects, on average, more than one other person, the epidemic grows exponentially.
It explodes.
But if the reproduction number is below 1, meaning an infected person passes it to less than one person on average, the epidemic shrinks.
And eventually disappears entirely.
Exactly.
Okay, think of it like a campfire. If you're listening right now, imagine you're sitting around a fire pit and you want to keep the fire going.
You need two main things.
Right. First, you need enough wood, which in this analogy represents the susceptible people in a population.
Fuel.
The fuel. And second, you need enough sparks, which represent the daily physical interactions between those people to keep the wood burning.
It's a great visualization.
If every log you throw onto the fire catches a light and then subsequently lights 2 more logs, that is an R0 of 2.
The fire roars out of control very quickly.
But if you spread those logs out so far apart that a spark from one burning log only has a 50% chance of catching another log.
That's an R0 of 0.5.
Right, and the fire inevitably dies out. So the fundamental question we have to ask is, how is our modern society designed to stack the wood and fan the sparks?
That question brings us directly to the concept of density, the spatial design of our world.
But Tassier makes a crucial fundamental distinction in the source material here.
He does. It challenges how we normally think about cities.
Yeah.
Not all density is the same.
Right.
We have to differentiate heavily between two very different types of concentration. what he calls upward density and inward density.
Upward density being the architectural hallmark of affluent areas.
Exactly. The affluent use their wealth to literally build vertically. Look at
Yeah.
the wealthiest neighborhoods in Manhattan, for example.
They possess incredibly high density when you measure them by traditional rudimentary metrics.
Like people per square mile.
Right, because you have thousands of people living on a single city block if there's a massive skyscraper there.
But the lived experience of that density is completely different than what the metric suggests.
How so?
The reality of upward density is one of isolation and space. Inside those tall buildings, residents have massive amounts of actual living space.
Multi-bedroom apartments.
Fewer people per household, private elevators, doormen to manage deliveries. They often have easy access to expansive outdoor parks.
So when a pathogen enters this environment,
These individuals possess the private, architectural buffers of safety required to isolate.
right, if someone in an upwardly dense building gets sick, they can retreat to a separate bedroom, use a separate bathroom, close the door,
The sparks are contained.
which is the polar opposite of inward density. This is where the impoverished are structurally packed into small living quarters.
The text gives us very specific examples of neighborhoods like Jackson Heights in Queens or certain parts of the Bronx.
In these inwardly dense areas, you aren't looking at luxury high-rises. You are looking at multi-generational families cramming into small, subdivided apartments.
Grandparents, parents, and children all sharing the same small bedrooms and a single bathroom.
When someone contracts a virus in that specific environment, isolation isn't just difficult.
It's physically, structurally impossible.
Returning to our campfire analogy, the sparks in Jackson Heights are bouncing around a completely enclosed, highly combustible space with the wood stacked directly on top of itself.
What is truly revealing about this structural divide is what happens when a city officially shuts down during a public health crisis.
Right, the lockdown phase.
If we look at the standard pandemic response, affluent areas characterized by upward density actually de-densify.
The non-essential businesses close their doors.
The daily influx of commuters, tourists, and shoppers from surrounding areas completely stops,
Furthermore, residents who have the financial means flee the city entirely.
retreating to second homes in the country or renting isolated properties.
Suddenly, there is an absolute abundance of extra space in these already spacious, upwardly dense neighborhoods.
The sidewalks empty out, the parks are clear of crowds, the interactions drop to near zero.
Consequently, the reproduction number in those specific zip codes plummets well below 1.
The fire is starved of oxygen.
I want to pause on that because the contrast is staggering. For the inwardly dense areas, a citywide shutdown doesn't result in de-densification at all,
In fact, nothing changes.
which perversely makes the situation much worse. These areas remain densely packed. Why?
Because the residents living in inward density still have to physically commute to essential jobs.
You cannot stock grocery store shelves over Zoom.
You cannot drive a city bus or clean a hospital facility or process meat from a laptop.
So when the rest of the city successfully shuts down to buy safety and lower their local R0, the inwardly dense neighborhoods do not gain a single ounce of that safety.
The residents are still forced to move through crowded public transit systems
Work in highly populated environments.
and then return to those crowded multi-generational apartments.
The wood remains tightly stacked and the sparks keep flying.
And this spatial reality perfectly transitions into the network design of our society. It's not solely about the physical space people occupy.
It's equally about how those people connect across the map.
To understand epidemic transmission, we need to thoroughly examine the concept of hubs and bridges.
Okay, I have a great analogy for you to visualize this network. Think of the airline route map you inevitably find in the back pages of an in-flight magazine.
The one with all the sprawling lines?
Exactly. You look at that map and you quickly realize that the vast majority of airports in the world are quite small.
An airport in Houghton, Michigan might only connect to one or two other places.
But then you have these massive critical nodes: Atlanta, Chicago O'Hare, JFK, and New York.
If a localized snowstorm shuts down Houghton, Michigan, almost no one in the broader network notices.
The system continues. But if a massive blizzard shuts down O'Hare and Chicago, the entire global network fractures.
Suddenly, flights in San Diego, London, and Tokyo are getting canceled.
And sociological networks operate on that exact same architectural principle, don't they?
They do. Most individuals possess average, relatively small social networks, but certain people, entirely by virtue of their employment or their community roles, function as massive social hubs.
Network scientists refer to the phenomenon where these high-contact hubs connect to other high-contact individuals as assortative mixing.
Essential workers, the bus drivers, the grocery clerks, the high school teachers, the hospital custodial staff are human hubs.
They are the O'Hares and ATLs of the viral network.
They are forced to interact with hundreds, sometimes thousands of different people daily.
If an infectious disease enters a city limits, it is mathematically highly likely to encounter one of these human hubs simply due to the volume of their interactions.
So the essential workers are the hubs, but then the text introduces the concept of bridges.
And this is where the mechanics of a pandemic get incredibly precise and, frankly, terrifying.
Sociologists refer to the spaces between distinct social groups as structural holes. A bridge is an individual who spans that structural hole.
They connect two entirely distinct groups of people who would otherwise never, ever interact.
Tassier's source material gives some devastatingly clear examples of how these bridges function to ignite outbreaks.
Let's look closely at the Biogen conference that took place in Massachusetts early in the COVID-19 pandemic.
The Biogen conference is a textbook example of network transmission. You had a scenario where a few hundred pharmaceutical executives and employees gathered in a hotel.
For a few days, that specific conference room acted as an incredibly dense, highly active super spreader hub.
The sparks were flying constantly in that localized environment. But the localized hub wasn't the true systemic danger.
The real catastrophic damage came from the bridges.
Because the conference eventually ended.
Right, and those attendees traveled back to their homes across the globe.
By getting on airplanes and returning to their disparate lives, they acted as bridges.
Completely filling the structural holes between that single Boston hotel lobby and entirely separate communities in Europe, Asia, and across North America.
The epidemiological tracking on this is astounding. Those relatively few individuals formed the bridges that ultimately sparked an estimated 250,000 global infections.
I just want you to sit with that number for a second. 250,000 infections from one room.
250,000 cases, all tracing back to the structural bridges formed by attendees of a single corporate event.
It really drives home the point that the virus doesn't just wash over a map like a wave. It travels along very specific, identifiable highways.
And the text provides an even more tragic systemic example of how these bridges operate, specifically looking at elder care facilities.
The elder care crisis is perhaps the most sobering illustration of this dynamic.
The text highlights a rigorous study conducted by researchers Chen, Chevalier, and Long.
They utilized anonymized wireless phone data to track the physical movements of workers.
During the strict lockdown period of the pandemic, this was a critical window of time when outside visitors were entirely banned from entering nursing homes.
The only people going in or out were the staff. So the residents were supposedly perfectly isolated, the facilities were locked down.
In theory, yes. But the researchers found a fatal flaw in the network architecture.
What did the data show?
The data revealed that less than 5% of the workers were moving between multiple different elder care fatalities.
Just let that metric sink in, less than 5%. But why were they moving?
These were often part-time workers, aides, and orderlies who were systemically forced to work multiple low-wage jobs at different locations just to piece together a living wage.
They didn't want to commute between 3 different nursing homes during a pandemic.
But their economic reality demanded it.
And in doing so, they became the human bridges.
Precisely. They acted as entirely unintentional yet highly efficient bridges.
Because those very few structural holes between isolated nursing homes were filled by this 5% of the workforce.
The virus was able to spread wildly among the most physically vulnerable population in the country.
The result of this specific network architecture, the study attributed almost half of all nursing home cases to this cross-facility staff movement.
Ultimately, 1 out of every 12 people living in long-term care died in the first year of the pandemic.
1 in 12.
That is a staggering mortality rate driven entirely by a predictable network vulnerability.
It is a devastating statistic, and it really forces us to look at the broader picture. So what does this all mean when we synthesize the geometry, the density, the hubs, and the bridges?
Tassier synthesizes this into what the text describes as the lightning strike effect.
Think about a massive thunderstorm rolling over a dry forest.
Our world's hubs and bridges, the international airports, the vital transit lines, the millions of essential workers act as the tall trees.
They are the entry points.
When a novel pathogen strikes these nodes, it ignites the first localized fires of an outbreak.
And then, because of the very way our society is structured, Those fires don't just burn randomly.
They are carried directly and efficiently over network bridges deep into the inwardly dense neighborhoods we discussed earlier.
The physical and social architecture of the city practically dictates exactly where the virus will travel and who it will turn.
It does. And what's fascinating here is that this architectural design does not exist in a vacuum.
Right, it's tied to our economics.
It is deeply, inextricably intertwined with the complex system of incentives that govern our society.
We have to critically examine what specific behaviors our economic and social systems reward and what behaviors they brutally punish during a crisis.
The source material points to a stark, undeniable reality. The system creates a severe dichotomy between those who possess the capital to afford what is termed plague insurance and those who are structurally trapped in a deadly double bind.
Okay, let's really break down this concept of the wealthy incentive first, this idea of plague insurance.
When a major pandemic hits, affluent individuals are heavily incentivized and, crucially, entirely able to use their accumulated wealth to literally buy safety.
They purchase remote work capabilities, outfitting home offices, and upgrading broadband.
They can afford the luxury of entirely isolated commutes, driving personal, private cars from their garages to their destinations, rather than packing into a subway car.
But perhaps most importantly, they use their capital to completely outsource their exposure risk.
Outsourcing risk is a massive component of plague insurance.
Affluent families utilize delivery services like Instacart or Ocado or Blue Apron.
Instead of walking into a poorly ventilated, crowded grocery store where the reproduction number might be spiking, they pay someone else to enter that dangerous environment on their behalf.
They effectively transfer their personal biological risk to a gig worker.
The wealthy are incentivized to retreat and pay others to bridge the structural holes for them.
Conversely, we have to look at the working pool, who face an entirely different, impossible incentive structure.
The text describes this as the double bind.
These individuals do not have the financial luxury of purchasing plague insurance. They cannot outsource their risk.
Instead, the system forces them to choose daily between two catastrophic, life-altering risks.
They must either risk physical exposure to a potentially deadly virus by continuing to commute and work at an essential, front-facing job.
Or they must risk the immediate, crushing threat of financial ruin, eviction, and family hunger by choosing to stay home and protect their health.
It is a choice that is no choice at all. The text provides a very concrete, visceral example of this double bind that puts the systemic cruelty into perspective.
Consider a meat processing plant worker making a wage of, say, $15 an hour.
During the height of a pandemic crisis, global and national supply chains inevitably fracture, and the cost of basic goods like food spikes dramatically.
Right. And how does that inflation affect different demographics?
Well, if an affluent family making $100,000 or $150,000 a year sees their monthly grocery bill jump by $240, it's an annoyance.
But they easily adapt. They absorb the cost.
They might cut back on a few luxuries. They skip a planned weekend trip, or they reduce how often they order takeout from high-end restaurants.
Their survival is never in question.
But the family of that $15 an hour meat processing worker,
Their economic reality is completely inelastic.
they are already spending every single dollar of their budget on the bare, non-negotiable necessities: rent, basic food, utilities, and transportation to work.
There are absolutely no luxuries in the budget to cut.
So what happens when their grocery bill spikes?
They face an immediate crisis of survival. Because they have no financial buffer, when the cost of living increases during the pandemic, they are perversely incentivized to keep working.
Forced, really.
They must continue to stand shoulder to shoulder on the line in a packed meatpacking plant, breathing shared, refrigerated air, just to afford the newly inflated cost of groceries.
The economic system creates an incentive structure that forces them to walk straight into the biological fire.
It is a devastating trap. And to fully understand how this trap is maintained, we also have to look upward at the institutional incentives.
How do the massive corporations employing these essential workers behave?
The analysis here is vital. The system consistently rewards large firms for treating their low-wage workers as disposable tools.
Optimized solely for profit maximization rather than as human beings who require deep systemic protection during a crisis.
The text provides the very specific case study of Ms. Hernandez, an essential worker at a Ralph's grocery store, which is a massive chain owned by the Kroger Corporation.
The experience of Miss Hernandez perfectly encapsulates the institutional failure of incentives.
She was a frontline worker facing incredibly hostile daily conditions. She wasn't just dealing with the invisible threat of the virus.
She was dealing with the very visible threat of the public.
Customers were cursing at her, throwing items in frustration, and aggressively refusing to wear masks or adhere to basic safety protocols.
She was the human shield between the corporation and the chaos of the pandemic.
And how did corporate governance respond to her situation? Did they alter their incentive structure to protect her?
According to the detailed analysis in the text, the response was characterized by profound corporate indifference.
The institutional incentive for a massive corporation like Kroger is to maintain continuous operations and maximize quarterly profit.
Especially when grocery demand is surging, they offered what the text describes as vacuous safety policies.
Measures that looked legally compliant and reassuring on corporate press releases, but provided almost zero tangible systemic protection for the workers on the actual front lines.
There is little to no systemic financial incentive for the corporation to heavily invest in the costly structural protection of its frontline workforce.
Particularly when the broader economic system treats the labor pool for low-wage jobs as entirely replaceable.
The burden of safety is pushed downward onto the individual worker, while the profits flow upward.
This shifting of the burden brings up a fundamental concept from economics that I think is absolutely critical for you to grasp if you are listening to this.
It explains so much of our societal dysfunction. It is the concept of externalities.
Let's break this down clearly.
Imagine a large industrial factory located on the banks of a river. If the factory owners decide to cut their operational costs by secretly dumping their toxic chemical runoff directly into the water, they save a massive amount of money.
Their profits soar.
But they have ruined the river for everyone living downstream. The downstream communities are now paying the actual price for the factory's profitable actions.
They are paying with dead fish, ruined agriculture, and toxic drinking water that causes illness.
The factory's behavior has created an external cost, an externality that is borne by society, not by the factory itself.
It is a perfect analogy, and we must apply it directly to public health.
In the specific context of a pandemic, exposure risk itself acts as a massive externality.
When a healthy college student decides to go out partying in crowded bars during a severe viral outbreak, or when an individual willfully refuses to wear a mask in a densely packed indoor space, they are actively generating exposure risk.
In their own mind, they might rationalize it by thinking, well, I am young, I have a strong immune system, the statistical risk to my personal health is low.
But the critical failure in that logic is that they are dumping their generated exposure risk directly into the shared social environment.
They are polluting the river.
Exactly. They pass the virus, perhaps asymptomatically, to a grocery clerk.
That clerk takes the virus onto a crowded city bus, where the air circulation infects a tired elder care worker.
That elder care worker, who we know from the data is likely working multiple jobs, brings the virus into a highly vulnerable nursing home.
The ultimate devastating cost of that college student's liberty to party is paid far downstream by the most vulnerable members of society with their health and their lives.
The societal incentives are completely structurally misaligned. Individuals are culturally and politically allowed to freely pollute the shared environment with viral risk.
And the marginalized are first to pay the ultimate cleanup cost, which means we don't have to guess what happens next. The outcomes are a mathematical certainty.
When you combine the geometric design of inward density that we discussed, where people are stacked on top of each other, with the perverse economic incentives of the double bind that force them to stay in motion, the results are not random acts of nature.
They are predictable disparities. This creates what the text grimly refers to as death zones.
The term death zones is not hyperbole. It is a tragically accurate descriptor for inwardly dense neighborhoods during an outbreak.
These specific geographic areas inevitably act as amplifiers for the reproduction rate of a virus.
Let's trace the exact mechanical path. Essential workers, who form the backbone of the city's infrastructure, overwhelmingly live in these neighborhoods.
They are economically forced to commute on crowded public transit.
They spend their days working in crowded, front-facing jobs, where they act as the hubs and bridges of the viral network.
Inevitably, they contract the virus.
And because they lack upward density, they bring that pathogen back into their cramped, inwardly dense, multi-generational homes.
The source material provides a harrowing, deeply human example of this exact mechanical path. Let's look at the Rivera family in Los Angeles.
This isn't just data. This is how the architecture fails a family in real time.
Betty Rivera lives in a single-bedroom apartment. She shares this tiny space with her adult daughter, her son-in-law, and her grandchildren.
It is the definition of a multi-generational household in an inwardly dense neighborhood.
When Betty inevitably became infected with COVID-19, she understood the danger. She tried desperately to do the right thing to protect her family.
But her architectural reality made protection impossible.
Exactly. She locked herself in the one actual bedroom of the apartment, a room she normally shared with her grandson.
The rest of the entire family, the daughter, the son-in-law, the kids, were all forced to sleep in the small living room to try and maintain physical isolation from her.
But it is a tiny apartment. They share the exact same ventilation system, the exact same circulated air. They have to share the single bathroom.
Inevitably, despite their absolute best, most conscientious efforts to isolate, the virus easily bridged the gap.
The daughter, the son-in-law, and two of the grandchildren all subsequently became infected.
The physical architecture of their lives practically guaranteed the viral outcome, regardless of their personal choices.
And when we scale that individual tragedy up and look at the data at a broad population level, the mortality disparities are staggering.
They reflect this exact, targeted architectural vulnerability perfectly.
The text provides specific data from the peak of the pandemic in New York City. The mortality rate for white residents, who are statistically more likely to have access to upward density and plague insurance, was 3.9 times their normal baseline death rate.
That is a terrible toll.
But when you look at populations of color, the numbers reveal the true lethal cost of systemic inequality.
The black population in NYC died at 7.2 times their normal rate,
The Asian population died at 7.7 times their normal rate.
and the Latino population died at an absolutely astounding 9.6 times their normal baseline rate.
Wait, I really need to stop and make sure we process that.
Yeah.
9.6 times the normal death rate. That means for every one person you would normally expect to pass away in a given month, nearly 10 were dying.
It's hard to even comprehend.
How does a single virus cause such a mathematically divergent outcome in the exact same city?
It happens because the virus is riding the transit system of pre-existing inequality. And crucially, this phenomenon wasn't confined just to dense urban centers like New York or Los Angeles.
Right. The text points to the profound tragedy of the Navajo Nation to illustrate how systemic neglect operates geographically.
The Navajo Nation historically receives far fewer healthcare resources and basic infrastructure investments per capita than the rest of the United States.
Many homes lack basic running water, making something as simple as frequent hand washing incredibly difficult.
As a direct result of this deep, systemic vulnerability, over 1% of the entire Navajo Nation population died from COVID-19 by mid-2022.
It is a crystal clear demonstration of the thesis. The biological virus does not discriminate, but our societal architecture absolutely lethally does.
It's devastating. And to really synthesize how all these different systemic failures, the housing, the jobs, the lack of resources compound on top of each other to produce these outcomes, the text uses a brilliant framework called the Swiss cheese model of risk.
Developed by James Reason. Think of several slices of Swiss cheese stacked together in a block. Each individual slice represents a layer of defense, a protective measure against a hazard.
In a pandemic, those slices might be the ability to work from home, access to high-quality masks, vaccines, or living in a spacious house.
Now, every slice of Swiss cheese has holes in it, right? The holes represent the inevitable flaws or gaps in those protections. No single protection is perfect.
But Reason's theory states that as long as the holes in the various slices do not align perfectly, the hazard of the virus cannot pass all the way through the stack. It will eventually hit a solid wall of cheese.
Let's apply this model to two contrasting fictional examples provided to illustrate the disparity. First, let's look at an affluent family living in Vermont.
They possess multiple, robust slices of cheese. Their first slice is employment. They have remote work capabilities, meaning they don't have to commute or interact with the public.
Their second slice is architecture. They live in a spacious single-family house, providing upward density and the ability to perfectly isolate if someone gets sick.
Their third slice is healthcare. They have excellent, high-quality private health insurance, ensuring strong baseline health and immediate access to top-tier doctors.
For this Vermont family, the holes in their Swiss cheese absolutely do not align. The virus might penetrate one layer, but it quickly hits a solid wall of structural protection.
But then we have to contrast that with the reality of an essential worker. The text uses the fictional example of Mr. Contreras, an individual living in California, to represent millions of real people.
Let's look at his slices of cheese. First, employment. He sells flowers on the street corner to make a living. He is a frontline essential worker in constant contact with the public.
That slice has a massive hole.
Second, baseline health. He has a persistent limp and underlying health issues. That slice has a hole.
Third, healthcare access. He has no high-quality health insurance, perhaps relying entirely on underfunded, crowded public clinics if he can manage to see a doctor at all. Another massive hole.
Fourth, architecture. He lives in crowded, inwardly dense housing.
For marginalized individuals like Mr. Contreras, the holes in the Swiss cheese are not randomly distributed. This is the crucial insight.
Systemic poverty ensures that these risks are highly structurally correlated. The lack of insurance, the reliance on essential front-facing work, the crowded living conditions, the poor baseline health, all of these structural holes are perfectly, tragically aligned by the system.
This perfect alignment creates exactly what the text terms a pandemic tunnel.
The virus travels completely unimpeded straight through the aligned holes, leading directly to severe viral exposure and catastrophic health outcomes.
The outcomes are correlated, they're absolutely not coincidental.
Which brings us to a really difficult, somewhat haunting question about persistence. If these outcomes are so meticulously predictable, if epidemiologists and sociologists can literally map out these pandemic tunnels based purely on zip codes and median income levels before an outbreak even starts, why does this keep happening?
Why do these highly unequal systems persist across centuries?
Because, as the text makes abundantly clear, this is not a new phenomenon unique to the 2020s. History is basically just rhyming over and over again. The exact patterns we saw with COVID-19 are centuries old.
The persistence of these systems is perhaps the most damning aspect of the entire analysis. The underlying systems of epidemic inequality are never fundamentally dismantled during the calm times, the periods of peace between pandemics.
Society collectively ignores the highly flammable architecture of our cities when they are not actively burning.
If we look closely at the historical constants, the parallels to our modern crisis are chilling. The source material takes us all the way back to Athens in the year 430 BCE.
Over 2,000 years ago, what were the exact structural conditions there?
During the Peloponnesian War, the Athenian leader Pericles implemented a military strategy to pull the rural population behind the safety of the massive long walls to escape the invading Spartan army.
Suddenly, you had roughly 355,000 refugees packed tightly into the city center.
This created an unprecedented historic level of sudden inward density. The sanitation systems were overwhelmed. People were sleeping in temples and public squares.
When an unknown disease, often referred to as the Plague of Athens, struck this newly formed tinderbox, it decimated the population precisely because of that forced structural crowding. The density dictated the death toll.
And we can fast forward a couple of millennia to see the exact same architectural failure.
Let's look at Naples, Italy in 1884. A massive cholera epidemic breaks out. But crucially, the disease does not hit the city equally. The geography of Naples defined who survived.
The spacious, well-ventilated, affluent upper city, situated on the hills, was largely spared from the devastation.
The catastrophic death toll was entirely, intensely concentrated in the dense, impoverished slums of the lower city, right near the water, where people lived in incredibly cramped, unsanitary, inwardly dense conditions.
We see another perfect historical mirror in Mumbai, India. During the catastrophic 1918 influenza pandemic, the text notes the specific, horrifying disparities.
The lowest castes, who were systemically forced into the most crowded urban slums and chawls, died at a horrific rate of 60 per 1,000 people.
Meanwhile, the British and European elites, living in the spacious luxury sections of the exact same city, isolated in large homes with private gardens, died at a rate of only 8 per 1,000.
Sure, it's the exact same architectural story, the exact same systemic failure, just different centuries and different biological pathogens.
So we have to ask the psychological question. Why does the dominant society continuously allow this brutal architecture to persist?
If we know the lower city of Naples or the slums of Mumbai or the apartments in Jackson Heights are going to burn, why don't we fix them during the calm?
The source material points to a profound psychological and sociological barrier, which is referred to as the empathy gap.
The text introduces a powerful concept from the great American sociologist W.E.B. Du Bois, who wrote extensively about what he observed as a peculiar indifference to the suffering of marginalized groups.
Peculiar indifference is a brilliant, unsettling phrase. Du Bois was observing how the dominant white society in America could look at the immense suffering, poverty, and ill health of the black population and feel absolutely no moral urgency to change the systemic conditions causing it.
And modern psychological research rigorously backs up Du Bois' sociological observation. Countless studies demonstrate a persistent, measurable empathy gap.
Where dominant societal groups literally fail to neurologically sense, register, or prioritize the pain and suffering of marginalized outgroups as strongly as they sense pain within their own in-group.
It creates a massive societal disconnect.
Exactly. This empathy gap allows for a profound cognitive dissonance. If the people who are predominantly dying in the death zones are continually viewed as the other in the working core, the immigrants, the racial minorities, the dominant culture, which holds the political and economic power, is far less motivated to fundamentally alter the underlying architectural system.
The suffering is contained away from them, so the urgency to dismantle the system vanishes.
And we see this peculiar indifference historically weaponized by figures like Edwin Chadwick in the 19th century. Chadwick was a major figure in English public health, writing reports on the sanitary conditions of the laboring population.
He looked at the immense suffering and disease of the poor during various cholera and typhus outbreaks. But instead of solely blaming the atrocious, overcrowded architectural conditions they were forced into, he basically concluded that their ill health was a consequence of their own bad moral choices.
He viewed their poverty and sickness as a moral failing, a lack of personal discipline, rather than as a glaring, lethal architectural flaw of the capitalist society he helped administer.
And if we flatter ourselves by thinking we have culturally evolved far past Edwin Chadwick's 19th century moralizing, the text points out that this peculiar indifference persists vehemently today.
We must look at the rhetoric.
When you hear pundits, commentators, or politicians aggressively arguing for immediately reopening the economy, or unmasking schools, or removing public health mandates without proposing any systemic regard, funding, or protective plan for the essential workers who will inevitably bear the absolute brunt of that increased exposure risk, you are hearing Edwin Chadwick's ghost.
It's treating the inevitable suffering of the working poor as an acceptable, necessary cost of doing business. It effectively blames them for not being able to afford their own plague insurance, while simultaneously demanding they show up to bag groceries and processed meat.
Precisely, which leads us to the critical realization of interconnection, the systemic web. We absolutely cannot analyze public health in a vacuum as if viruses exist separate from the economy.
Epidemics interact continuously and aggressively with larger economic, historical, and political systems. To truly understand modern epidemic inequality, we must meticulously understand the specific historical inequities that literally drew the current maps of our cities.
Now, drawing strictly from the objective, systemic analysis provided in the text, we can clearly see how historical policies act as direct mechanisms linking to modern health outcomes. We are exploring the text impartially here.
Right, let's look at the mechanics of the wealth gap in the United States as it is detailed in the source material.
The text points to a staggering metric. A median white household wealth of roughly $144,000 compared directly to a median black household wealth of just $11,000. That is a massive multi-generational discrepancy in capital.
And the text carefully points out that this map of wealth did not occur by accident or natural law. It is the direct, systemic, mechanical result of specific historical policies, particularly post-Civil War Jim Crow laws and the New Deal-era practice of redlining.
Let's examine the mechanics of redlining specifically. During the 1930s, the government-sponsored Homeowners Loan Corporation literally drew red lines on city maps around predominantly black and minority neighborhoods, deeming them hazardous for investment.
These policies institutionalized geographic segregation. Crucially, they specifically and systematically denied government-backed mortgages and home loans to black families living within those red lines.
Simultaneously, the system actively enabled white families to secure low-interest loans, move to the suburbs, buy homes, and begin building substantial home equity.
And home equity is the primary engine of multi-generational wealth in America.
It is. By systematically denying minority populations the fundamental ability to build that equity and wealth decades ago, those specific historical policies created a severe, compounding disadvantage that fully materialized in the year 2020.
Because, as we established earlier, wealth is the sole currency used to purchase plague insurance. When the pandemic hit, that $11,000 median wealth meant that millions of minority families had virtually no financial buffer, no savings to fall back on.
They physically could not afford to isolate, they could not afford to skip shifts at work, and they certainly could not afford to move to safer, upwardly dense areas.
The historical act of redlining essentially pre-drew the geographic boundaries of the modern death zones.
We are exploring the systemic analysis provided by the author here. The legal and financial structures of the past act as literal functioning mechanisms for disease spread in the present.
It is a profound, undeniable interconnection between a map drawn in 1935 and a hospital admission in 2020.
And another major system we have to look at through this lens is the for-profit healthcare system. Let's use a comparative analogy to make this clear. Think about our public education system.
As a society, we generally manage to put a public elementary school in virtually every single community, right?
We do not decide whether or not to build a local school based on whether that specific building will turn a lucrative corporate profit at the end of the fiscal year. We deem it a necessary public good.
But the text argues that by explicitly treating healthcare as a profit-maximizing industry, we allow corporate medical conglomerates to dictate exactly where health clinics, urgent cares, and full-service hospitals are geographically located.
And the predictable outcome of that specific profit-driven incentive structure is the systemic creation of vast preventative care deserts.
Corporate healthcare models rigorously analyze demographics. Low-income urban areas and sparsely populated rural communities are simply not deemed profitable enough to warrant heavy capital investment.
Consequently, existing hospitals in these areas are closed, new clinics are scarce, and specialized doctors move to more affluent zip codes.
The residents left behind in these deserts are structurally denied consistent, high-quality preventative care.
Which means they enter the pandemic already at a massive disadvantage.
Exactly. Because they lack access to routine care, they inevitably go into a pandemic scenario with statistically much higher rates of underlying unmanaged conditions, diabetes, hypertension, asthma.
They have no strong baseline health defense.
From a systemic perspective, we are effectively leaving the most historically vulnerable populations completely structurally undefended before the novel pathogen even arrives at the city limits.
And finally, in weaving this web of interconnections, we have to examine the politics of individual liberty. And again, I want to be clear that we are analyzing this purely structurally based on the text's framework, not taking an ideological or partisan side.
The reality is that political leaders face heavy, constant pressure and are deeply incentivized to appease public calls for individual liberty and personal choice.
For example, making public health measures like masking or social distancing entirely optional rather than legally mandated.
When we impartially analyze the systemic mechanical outcome of that specific political choice, it brings us full circle back to the economic concept of externalities.
By officially ceding the public health response to the realm of private individual choice, the political system effectively legalizes the pollution of the shared environment.
It legally allows individuals who perceive themselves to be at low personal risk to act in ways that drastically increase the collective exposure risk for everyone else in the network.
What this does, structurally and mechanically, is force a massive public collective threat, a highly contagious airborne virus, to be adjudicated entirely through private individual resources.
It privatizes survival.
If the state steps back and removes collective mandates, your ability to survive the collective threat depends entirely, 100%, on your own private bank account's ability to buy plague insurance and your own private immune system's baseline health.
Which, as we have thoroughly established through the data, are highly intentionally unequal.
It creates a system where the strong are legally permitted to expose the vulnerable, and the vulnerable are left to manage the biological fallout alone.
Which feels like the perfect, devastating setup for our final question. I really want you listening to think about everything we've mapped out today. The density, the bridges, the double bind, the redlining.
So, what is the crisis in perception here? What is the grand illusion that society is collectively falling for?
The profound crisis in perception is the deeply held, aggressively maintained false belief that pandemics are great equalizers. We are culturally conditioned to believe that viruses strike randomly, moving across the map like a blind force of nature.
Like a hurricane or an earthquake.
And subsequently, we falsely believe that surviving a pandemic is purely, solely a matter of individual medical risk and personal hygiene choices.
We ask ourselves if we washed our hands enough times today, or if we took our vitamin D supplements. Did I personally choose to wear a mask in the store? We individualize a collective phenomenon.
But the systemic reality we've explored today is completely fundamentally different. The text makes it undeniably clear. The system actually operates on a shared, interconnected exposure risk that is entirely collective.
Disease distribution is not a lottery. It is a highly predictable, mathematically certain consequence of our engineered inequality. If we wanted to, we could map out exactly which specific zip codes and which specific demographics would suffer the highest casualties before the very first case even landed at the airport.
We chronically misunderstand this reality because our society is hyper-focused on the eye of individual medical management. We are obsessed with personal biology. Consequently, we completely fail to see the we of the social architecture.
The deeper causal structure is obscured by our individualism. We must realize that systemic inequality isn't just a sad, unfortunate secondary side effect that happens alongside an outbreak.
Systemic inequality is the actual physical fabric across which the outbreak moves. The virus literally uses our economic disparities, our crowded transit lines, our underpaid essential workers as its transit system.
Inequality is the fuel that turns a small, manageable biological spark into a raging, uncontrollable social firestorm.
It fundamentally reframes everything about how we view a crisis. And it leaves us with a final provocative thought for you to chew on as we wrap up this deep dive. Because the calm will eventually end.
When the next novel pathogen inevitably arrives, and the math guarantees that it will, where will your focus be?
Will you be looking down the narrow lens of a microscope, obsessing over the biological traits and protein spikes of the virus?
Or will you be looking out the window, critically examining the sociological traits, the red line maps, and the structural vulnerabilities of the city it just landed in?
Are we, as a collective society, finally willing to do the hard work of dismantling the architecture of epidemic inequality during the calm?
Or will we simply wait for the next storm to arrive, rely on our personal plague insurance, and act surprised when the exact same vulnerable neighborhoods burn to the ground yet again?
Crisis in Perception examines how systems shape belief and how better tools help us see clearly. This project is free and publicly accessible. If you'd like to support the time, tools, and research behind Crisis in Perception, you can become a supporter on Patreon. For a shorter visual overview of this topic, see the mini explainer link in the description. If you enjoy this kind of systems-level analysis, please like, subscribe, and comment with books or topics you'd like us to explore next.